Our next presenter is Dr. Maziar Divangai from McGill University Health Center.
Thank you very much for this wonderful invitation. I guess you don't have my my video. Can you hear me?
Yes, you're loud and clear. Give our technical folks just a moment to see if we can bring the slides up.
Yeah. Okay.
There you go. Well,
That's not mine, actually. Sorry.
skip forward to you. Hang on just a second.
Yes. Okay. I guess the task that's been given to me today is to discuss a little bit more about the science behind designing vaccine for TB, which has not been successful, and why it's not been successful, and what we potentially could do to make a successful vaccine. So next slide, please. I guess we could go to the next slide. Next slide. Yes. I guess the reasoning is that, why we haven't been able to develop an efficient vaccine or effective vaccine against TB. And TB is going on around for quite a long time. And as one of our colleagues today mentioned, BCG is the only available vaccine for TB, which has been discovered almost a century ago, and only provide protection against the disseminated form of the TB in children, but has no efficacy in adults. I guess the reasoning really goes back to our fundamental lack of understanding of immunity to TB is the major gap for developing a novel therapy or vaccine against TB. And as Anne mentioned, the major question, we are still struggling to understand what is the correlate of protection. And if we don't know what is the correlate of protection, then of course we can design a vaccine against any infectious diseases. Next slide, please. So, I basically break down this presentation in two phases. One phase is that what we don't know about the pathogenesis of TB, and the next phase, I will talk about what we don't know about developing a vaccine against TB. Okay, next slide, please. So briefly, I guess I just like to tell you that how we get infected with MTB. MTB infect human mainly through the airways. They reach to the lower airways. Then they usually face at the beginning alveolar macrophages, which are the immune cells sitting in the lower part of the airway. And subsequently, these macrophages try to kill MTB, but often they are not successful, and ultimately they will take the bacteria from the airways into the interstitial tissue, and that's the place they form granuloma, which is a mixed bag of both innate and adaptive immune cells. And at that stage, what hosts try to do is basically to prevent the dissemination of bacteria to other organs. And often the bacteria stay in the center of this granuloma within the macrophages and still able to replicate at a very low rate. So there is this early phase of response, and then you have the chronic phase of the response. I guess the optimal vaccine for TB will be the vaccine that target that really early phase, the phase that the bugs are still in the airways and within those macrophages, and we haven't reached to the whole complex system of immune response when we form granuloma. So how can we do that? First of all, we need to understand what are the differences between macrophages, alveolar macrophages, these residential macrophages, and then monocyte-derived macrophages that coming from the circulation. Next slide, please. So clearly, we now know that the ontogeny of these cells are different. Alveolar macrophages are coming from the yolk sac and fetal liver, and they come at the very earliest stage of lung development. They seed the airways, and these are the cells that really trying to clean the airways, and also, if anything, reach to the lower airway to destroy them. And then if these cells are unsuccessful, they will recruit the monocyte-derived macrophages that coming from the bone marrow to fight the infection. So one of the questions that we had was, what are the differences between these two cell types when they face MTB? Next slide, please. Next slide. So what we have done, actually, we decided to do bronchoalveolar lavage to isolate these alveolar macrophages from the airways of humans, and then compare them with respect to infection to MTB, and then compare them to the also monocyte-derived macrophages from the same patient. So we isolate macrophages from the circulation as well as the macrophages from the lung. And then we infect them with the MTB, and then we look at their cellular metabolism. So next slide, please. So as we could see that the cellular metabolism of AM is really not good to fight the infection, because their metabolism is reduced after infection, while the metabolism of monocyte-derived macrophages that coming from circulation is increased. And we know that the increased level of the macrophage metabolism correlates very well with how they could provide protection against MTB. Next slide, please. Ultimately, we know that if alveolar macrophages, indeed, they have a metabolism that provide a better environment for growth of the bacteria, while the monocyte-derived macrophages that coming into the lung, they have a metabolism that are able to kill Mycobacterium tuberculosis. So maybe that's why evolutionary alveolar macrophages are the first cells that get infected with MTB, and MTB is able to grow within these cells. So the question is that if monocyte-derived macrophages are good in killing against MTB, what would happen if MTB get access to the bone marrow? So next slide, please. So we know that these cells are very good in killing. They're coming from the bone marrow, and bone marrow is basically the site for all the progenitors that generate immune cells, including these macrophages. Next slide, please. So one of the things that we observe actually in the animal models of tuberculosis, next slide, please, we found out that when we infect a mouse with the MTB, with the regular 50 CFU, we aerosolize them, we found that actually within 10 days, MTB get access from the airways into the bone marrow. And what it does in the bone marrow, it actually increases the expansion of stem cells and the progenitor cells that are required to generate immune cells. And when we carefully look at the bias of these cells in the bone marrow, next slide, please. Next slide. Next. We found out that actually MTB preferentially will inhibit the generation of myeloid lineage and the generation of monocyte macrophages, while there is expansion of the lymphoid lineage, which are responsible for generating B and T cells. Next slide, please. So what is the consequences of MTB get access in the bone marrow is that they could then reprogram the entire hematopoietic stem cells and progenitor cells. And through collaboration with Dr. Luis Bajero at Chicago University, we have shown that indeed this reprogramming has been transmitted all the way from HSCs to the progenitor of the monocyte macrophages. Next slide, please. And then what we could see that, of course, there is reprogramming in these HSCs that has been transmitted all the way to the progenitor of monocyte macrophages. But I think the interesting part is that, next slide, please. When we actually generate macrophages from these infected stem cells in the bone marrow, and then reinfect them with MTB in vitro, the macrophages that are coming from the infected MTB animals are more permissive to the growth of MTB in vitro. So indeed, when we recruit these macrophages or monocytes that are going into the lung to fight the infection, they have been reprogrammed at the level of the HSCs that they are no longer able to do the job that they need to do and kill Mycobacterium tuberculosis. Next slide, please. Next slide. So that's like one aspect that we don't know about the pathogenesis of TB. But what we don't know about the correlate of protection against TB. Next slide, please. So natural immunity to infection usually start with the activation of innate immune response that leads to the generation of effector adaptive immune response, in particular effector T cells. And then, after most often we are able to eliminate the pathogen, and then we will generate memory B and T cells, which is basically the foundation for generating a vaccine against many infectious diseases. Next slide, please. Next slide. And this foundation basically help us to generate vaccine, including the current vaccine that we have against SARS-CoV-2. We use a different platform, either viral or messenger RNA platform. We overexpress an antigen from the pathogen that leads to the generation of effector memory T and B cells, and ultimately generation of neutralizing antibody, which is the cornerstone for many vaccines that's been worked in humans. However, if you look at TB, next slide, please, the natural immunity to TB is neither able to completely eliminate the bacteria, nor to generate a protective memory response to prevent the subsequent reinfection. So this model system that's been worked very well against other infectious diseases maybe not be suitable for TB. Next slide, please. And because of this, basically all the vaccine, as many of my colleagues explained today, are designed to really promote antigen-specific T cell responses, in particular CD4 T cells, against MTB infection. And this has been basically rooted from the time that, we discover, Miller and Cooper discover actually T cells. Bob North shows that, that the thymus-derived lymphocyte contribute to containment of TB independent of antibodies. And then, of course, HIV infection that show that reduction of the T cells contribute to susceptibility to TB. And the main factor that we are targeting T cells is actually their memory capacity. However, next slide, please. We and others have shown that, not necessarily generating a high level or high numbers of antigen-specific T cells, provide protection. So this is an example that we manipulate a protein in mitochondria, and now we are able to increase the metabolism of the T cells. Next slide, please. And in these animals, when we infect them with the MTB, we could generate really a massive number of both antigen-specific CD4 T cells and CD8 T cells against MTB. And when we look at the protection, next slide, please, we found that this increased level of antigen-specific T cells did not correlate with the protection. Not only it didn't correlate with protection, but also increased the susceptibility of hosts to MTB infection, mainly to the increase of immunopathology in the lung. Next slide, please. Next slide. Next slide. And in fact, when you look at the literature, there's some really amazing work that's been done to show that T cell can promote the pathogenesis of TB. This is a really great work, is one done by Joel Ernst and Sebastian Gagnon, and they show that the mutation rate in MTB is extremely low. And the human T cell epitope of Mycobacterium tuberculosis are evolutionary conserved. So that's one argument that, really suggests that, the function of the T cells, conventional T cells in TB might be different compared to any other pathogens, because if you look at the viral infection, including influenza virus, you see that there is quite a high rate of a mutation because they want to escape these antigen-specific T cell responses or B cell responses. And next slide, please. And similar to what we have shown in the mouse model, there's a studies from Dan Barber at NIH actually showing that tuberculosis following PD-1 blockade for cancer immunotherapy, actually you activate TB in the cancer patient that received PD-1, which leads to the increase of the T cell responses in these patients. So again, not necessarily having more T cells correlates with the protection against TB. Next slide, please. And then, some of the vaccine that has been really generated a fantastic antigen-specific T cell responses, either in the infants or in adults, really did not translate to a better protection against TB. These are two examples. We talk about the M72, which again, that's very promising, but the numbers against, as it's been mentioned, is still very low. So we're talking about 13 individuals that were more protective than the 26 individual in the placebo arm. Next slide, please. So if, we have been concentrating on adaptive immune response for quite a long time in MTB, and the question has been raised recently, or maybe since last 10 years. So what is the evidence of innate immunity in MTB elimination? So there are a couple evidences. One evidence is that approximately 20% of individuals living in hyperendemic TB are TSD negative and resistant to TB. And approximately 50% of close household contact patients with active TB are TSD negative and resistant to TB. So these epi data really suggest that there might be a major role in innate immunity against MTB elimination. So what do we know about the innate immunity in terms of the memory? Next slide, please. So basically the question is that does innate immunity have memory like capacity? Next slide. So next slide. I mean, if you look at evolutionary at all the species on Earth, approximately 95 to 99% of all the species on Earth only have innate immunity. So they're only between 1 to 5% that they have adaptive immunity. Next slide, please. So it's imperative to consider that the critical evolutionary trait, like immunological memory, must be evolved in innate arm of the immunity as well. Next slide, please. So if you look at the simple organism like a plant, you see that, they don't have any adaptive immunity, but they have actually a program called systemic acquired resistance that provide a long-lasting signaling mechanism against secondary infection. Next slide, please. If you look at, invertebrates such as copepod, if you infect them with the tapeworm and then you go back and reinfect them with the same tapeworm, you see that the initial the copepod that has been initially infected with tapeworm provide a better protection against the secondary infection. And again, these insects only have innate immunity. And most recently, next slide, please. In human, we see that, indeed, the innate immune response could have a memory capacity, and this memory is mainly epigenetically reprogrammed in these cells and has been termed trained immunity. Next slide. So what are the evidence of trained immunity in TB? So as I mentioned, BCG is the only vaccine that has been used, and basically around more than 3 billion people intradermally vaccinated with the BCG, is effective in children, but not in adults. And the most prominent T-cell antigens that has been used for generating vaccine against TB is missing in BCG. And there's no direct link between the BCG specific T-cells and protection against TB. So we start this study with the BCG. Next slide, please. And as a proof of concept in the mouse model, we show that actually BCG can reprogram hematopoietic stem cells in the way that now we generate a monocyte macrophages, in contrast to what we have seen with TB, that are able to provide a better protection against MTB infection. And it was important, it is important to mention that the route of BCG vaccination in this system was intravascular vaccination. So we want to make sure that BCG is systemically disseminated to other organs, including the bone marrow. Next slide, please. And when we look at the history of a BCG IV vaccination or intravascular vaccination, if we go back even to 70, we could see that BCG given IV to the non-human primates provides significantly a better protection than any other route of vaccination. And then there is this beautiful study came out recently from Bob Cedar group in at NIH, showing that BCG IV vaccination indeed could prevent tuberculosis. I think this is a huge step, because now we are not talking about preventing the disease, actually preventing infection right from the beginning, which I think is really, really important. Next slide, please. And then what we also observed with the BCG vaccination in the mouse model, there is a recent study that has been published by Mihai Netia and Luis Bajero that show that exactly the same programming that we observed in the BCG vaccination in mouse model is actually happening in the human. So these are the human that has been bone marrow has been collected before vaccination and 3 months after vaccination with the BCG. These are naive human that's been vaccinated with the BCG. And then when you look at the reprogramming of the hematopoietic stem cells, they're very much identical to what we have seen in the mouse model. They really promote a unique reprogramming in the myeloid progenitor cells. They generate these unique monocyte macrophages that are very good in dealing with the MTB infection. Next slide, please. So ultimately, I just like to mention that, yes, we could harness the power of innate immunity in terms of the vaccine against TB. One way that we look at this, we could actually reprogram stem cells in the bone marrow through different route of the vaccination that has been used. And this could generate a very strong innate immune response that is able to fight the infection at the very earliest stage of infection, MTB infection. On the other hand, we also need to consider that, you know, after MTB infection, the bugs get access to the bone marrow and they reprogram and remodel the entire bone marrow and hematopoietic stem cells in the way that they're able to generate an immune response that is more beneficial to MTB rather than to the host. And evolutionary MTB actively suppress trained immunity via this particular region called RD1, a region of deletion 1, which is a single DNA region of difference and its absence in all BCG strains, but present in MTB. So I guess, you know, what I like to indicate that we still don't understand very well the pathogenesis of the TB. We still really don't know what are these T cells are doing. Are these T cells are more important in the granuloma and preventing the dissemination of MTB to other organs? rather than are these T cells are more important to in protection and killing MTB. And we also need to consider that there is a big arm of the immune response that called innate immunity, and we could definitely start thinking of how we could modulate and use this arm in order to generate a protective vaccine against TB. And combination, I think, of these two arms of the immune system perhaps will give us a better chance to find an effective vaccine against tuberculosis. Thank you very much.
Thank you. Our next presenter is Dr. Daniel Hoft, who's one of our committee members and is from St. Louis University. Daniel, your slides are up. You have the floor.
Thanks, Bob. And thanks to the organizers for inviting me to give a talk, and that second one, it sounds like, on conventional and unconventional T cells. Mine has a different angle than Maz's, so bear with me. I'm also going to be talking about the role of controlled human infection models in studies of TB immunity. My disclosures are I've been funded by multiple sources, including the Gates Foundation and industry awards and NIH, and I have an application for a patent on a gamma delta T cell vaccine antigen. I can do this, I think. Yeah. So I'm not going to spend any time on this because all the other speakers have really covered this very nicely. I just want to point out, as others have, that latency is the largest reservoir of the organism. So that's definitely something we need to focus on for practical reasons. The vaccines that are being developed now are not easy to test for that. So it's still an important thing that we need to work on. Perhaps mucosal immunity, which we don't have vaccines now going into the clinic yet, at least, could prevent infection. And perhaps if we have better antigens that are expressed by the latent organisms, we could have better penetration and clearance of the late infection. But those are aspirational goals at this point. The TB granuloma has been mentioned, and that's another special condition that's a challenge for TB vaccine development. The organization of these histopathologic structures do wall off the organisms. There's some evidence that this environment benefits both the host and the pathogen. And again, we need to be able to learn how to develop vaccines that can clear the organisms inside these granulomas to be able to have a clearance effect on latency. The major target has also been mentioned too for TB vaccine development for about, I guess, 40 years at least. The Th1 cell, the CD4 positive Th1 cell that makes interferon gamma, TNF, and IL-2 are key for protective immunity, but they don't seem to be enough to do better than what BCG is doing at this point. There's also other subsets of CD4s, such as Th17 cells making IL-17 that may be important, inhibiting regulatory T cells. And CD8 cells also might have a role. Mucosal immunity is critical. I'll say that again, and that's one thing that we're interested in studying. This has already been described, the classic vaccine, the Bacillus of Coumadin-Guerin, that we've used for 100 years now. And it's an attenuated version of Mycobacterium bovis, and it's still recommended in hyperendemic countries for TB that all infants, the first day or first month of life, get vaccinated intradermally, which is important with this vaccine. It's highly protective against the worst forms of TB disease and mortality, but not as good against TB infection and TB disease progression, especially in adults. There's been no great evidence of a vaccine so far lowering TB prevalence. BCG hasn't done that. We've had massive amounts of TB infection. We've had the highest numbers of deaths from TB and from any other infectious disease. So we have to learn more, as everyone else has been saying. So to conventional and unconventional and novel TB vaccines, Maz introduced the concept that perhaps we can induce a memory in the innate immune cells, which could be protective. My unconventional comment is more looking at different subsets of T cells that are different from the classic ones that have been targeted so far. This list here is a short list of the types of vaccines that are going into the clinic and advancing, and they're all alpha beta T cell targeting vaccines. And these antigens that they're trying to get an immune response against are restricted by highly polymorphic HLA molecules. There's thousands of them expressed by the global population. That creates a huge challenge for trying to make a vaccine that could protect everyone. You need all these different epitopes to be able to induce responses in different individuals. The other type of T cell that I'd like to introduce is not just one type, but can be grouped as not HLA restricted. What does this mean? They're still T cells. They express a alpha beta T cell receptor or a gamma delta T cell receptor that has not been introduced yet in this panel, which is just another type of T cell that's rearranging two separate genes. Other than the alpha and beta, there's a gamma and delta gene that rearrange to make the two chains that result in the antigen specificity. We call these unconventional cells DIRT cells I didn't like it in the beginning, but it makes sense. Donor unrestricted T cells. That's the acronym. And you can think of them as potentially being more universal vaccines. Why? Because everyone expresses the restriction elements that are important for activating these DIRT cells. So, and they're non-polymorphic, so they don't change, the same in everybody. So the same antigen theoretically could induce a protective response in everyone in the world, or a large proportion of them. That's what's different. These universally relevant, as I've called them, DIRT cells come in multiple different varieties. I already mentioned this. There's alpha beta TCR expressing cells, gamma delta TCR expressing cells. I'm just going to talk about two of them. They all have in common that they're activated by non-polymorphic conserved elements across the population. The two that I'll discuss are the gamma 9 delta 2 T cells that are restricted by conserved butyrophilin 3A1 and other molecules. And the other will be the mate cells, or the mucosal associated invariant T cells, that are restricted by the most evolutionary conserved non-polymorphic class 1-like molecule, MR1. We've been working on gamma 9 delta 2 T cells for about, I guess, 25 years now. We started off doing human trials with BCG, and we found that this population of gamma delta T cells, gamma 9 delta 2 T cells, were able to develop a memory after BCG vaccination. That got our attention because to have long-term protective immunity, typically you have to be able to induce a memory so the response can come back after re-exposure. We first found that these cells develop memory, like I said, but also we found that those memory cells could recognize TB-infected human monocytes and inhibit the replication of the organism intracellularly. We then went on to find an antigen from the cell wall of MTB, which is not a simple protein antigen like most of the conventional T cells respond to, but a methyl glucose lipopolysaccharide, kind of a nightmare for a vaccine developer, perhaps, but there's some good news coming. This MGLP is just shown schematically here. That's probably not important for this presentation. But we've had challenges with trying to develop a vaccine with this because of its nature. It's hard to get enough of it from the virulent organism to be able to do studies, for example, in non-human primates. And it's coming from the pathogen, and no company would ever want to try to make a vaccine directly from the pathogen. So we were able to get enough of this MGLP antigen to induce not an immune response by vaccination in non-human primates. At the top on the right, you can see that in both the blood and the lung of the monkeys that we vaccinated with MGLP, they had a significant induction of the gamma 9 delta 2 T cell population. And in the bottom, that shows that that translated into reduced organism load after an MTB challenge, as well as less pathology. Our breakthrough in the last 6 months on this project is that we've learned how to synthesize the active part of MGLP, and it's just a tetrasaccharide on the non-reducing end of the molecule. And when we take that and induce gamma 9 delta 2 T cells in vitro, they expand and they also can inhibit intracellular mycobacteria. So it looks like we have the structure activity relationship, or the biologically active part of the molecule, that's in a synthetic form that we could then make in GMP safe mass production and go into clinical trials, which is what we're trying to do, but we're not quite there yet. The second project that also focuses on the dirt and specifically the mate cells that are restricted by the MR1 non-polymorphic restriction element. It comes up in this study, which we weren't looking for these cells. We wanted to know what was the difference between a mucosal vaccination and a systemic vaccination in humans. So we had already done vaccinations with both intradermal BCG and oral BCG in humans. And we compared later on those two groups of people with negative controls that had no evidence for BCG vaccination or infection with TB in the past, and positive controls, people with latent TB infection. We recruited groups of about 15 of each one of these types, and then took blood and also did bronchoalveolar lavages and looked at the BAL cells for what they would produce at the transcriptional level after restimulation with mycobacterial antigens. And we found that the latent infection positive control, those individuals had memory Th1 and Th17 cells in both their blood and their lung. So they were good positive controls. And that combination may be why there's partial protection in people that are previously infected with MTB. But the intradermal vaccination, it was able to induce a strong response in blood, similar to in the latently infected people, but it didn't induce much of anything in the lung. In converse, when we studied the people that had gotten oral BCG, we found that they had a weak response in the blood, but they had the strongest response of all the groups to the mycobacterial antigens in the lung. So that got our attention. We further data mined the transcriptomal data and found evidence that mate cells were being involved in this oral BCG response. We haven't proven it, but what we have are evidence that in the orally vaccinated individuals, that was the only group that among their lung cells had a significantly elevated level of the MR1 restriction element for mate cells. And we also found a number of other genes expressed that are associated with mate cell functions. So we haven't proven this, but what we think has happened is that we give an oral vaccination with BCG. There's lots of mate cells in the gut. They tend to accumulate there. They get activated. They do traffic to the lung, and they're poised to be able to more rapidly respond to a recall exposure to TB. But we have a long ways to go for this project. But the idea that I just wanted to propose was that, and this suggests that perhaps what we need to do is actually use BCG by two routes together to be able to get the best combination of mucosal and systemic immunity. The last thing I'll talk about is the human challenge model that we're developing based upon our work with intradermal BCG vaccination, where most people know that have ever worked with it. It does cause a pustule to form, which then ulcerates, and there's drainage of fluid that contains viable BCG as long as the sore is open. So we sort of crazily decided to think about that reactogenicity as a way to develop a challenge. We have seen evidence, that I can't point, but in the middle there, that's our idealized curve of BCG shedding after an intradermal vaccination. We have seen that happen. So we thought we could bring the volunteers in twice a week during the time of the open lesion and swab the arms and measure the amounts of BCG being shed as an estimate of the total in vivo replication of mycobacteria to be able to have a challenge model that actually can measure mycobacterial load and how that is affected by previous vaccine-induced immunity. That's the whole deal here. So we've done one study so far with this, and that shows the feasibility. We did a dose escalation in mycobacterial naive individuals, no previous vaccination or infection, to try to standardize the model. We went from 2 million CFUs up intradermally up to 16 million. The 3 lowest doses were tolerable. The highest dose was not. So we only did the 2 sentinels in that group and did not proceed to do the whole 30. But what we found was that we could safely generate these lesions that shed BCG. And when we looked at the shedding patterns, we found that on the left, you can see the black squares. Those lines are men's shedding responses for PCR, CFU, and midget time to positivity. The open circles are women. And it's obvious, and we showed it biostatistically, that there's significantly higher shedding of BCG by men than women. This fits the epidemiologic pattern of men having a higher risk of TB disease progression. We found 4-fold more genes being switched on in women, which may be associated with preventing the level of replication happening in vivo. So we're data mining that now, trying to figure out what are the potential responses that are different between men and women to help inform us on how to make better vaccines. On the right, we found a list of 19 genes that if they were altered in the first week after the challenge, that predicted significantly lower levels of the area under the curve total shedding pattern. So we may have a putative protective signature, but we can't say that really with any confidence now. We've only done it in one study. We have a second study coming up that the VTU is funding to actually confirm that in a group that got BCG vaccinated first, they would have significantly less shedding in this model than people that hadn't been vaccinated first. So it challenges for novel TB vaccine development. We need more basic discoveries done. We need to translate them into humans. Challenge models can be used to help. And we want to make sure, and the model I've described will only measure systemic immunity, not mucosal immunity. And we need to do more with looking at the mucosal protection. But we can at least confirm whether or not, say, a gamma delta targeting T-cell vaccine can have some protection against mycobacterial replication in vivo. There's, like everybody said, chronic inadequacy of funding. There's expensive and prolonged clinical trials that are required. And we don't have as much disease here as in low and middle income countries. So the high income countries don't get incentivized really to work on the vaccines. Despite this, TB remains a major global threat, including in the United States. and everywhere due to globalization, the development of drug resistance, and the requirement for long-term treatments that can be toxic. So we need to learn more. That's, I think I've said that at least 3 times now. That I think is the bottom line, but we're making progress. And I hope that the current vaccines that have gone into the later stages will be more successful than BCG, but I want to have some backup. Thank you very much.
Thank you, Daniel. And our final presenter in this panel is Lois Priverdom, who recently retired from Johns Hopkins University.
Great.
Priverdom, you have the floor, and congratulations.
Thank you. Thank you. And you've heard a lot of data today, and I think it's very clear that there is a very real global threat. This area has been very much underfunded and really needs some acceleration to move forward. I'm not going to focus on the global picture so much. I'm going to try and get you to start thinking about some of the considerations that will need to be put in place for a TB vaccine in the US. And recently, the WHO has issued their investment case for TB vaccines globally. So what this does is it provides somewhat of a framework of where some of the gaps and where some of the things that you need to think about. Oops, why is this not moving? Okay. So we do know that TB is a big problem globally, and that we really need to do something about it. Vaccines do need to be accelerated. There are a very significant number of cases of TB. And when you think about it, the burden is tremendous. Every 20 seconds, someone is dying from TB around the world. Now, in the US, those cases are relatively low comparatively, but this doesn't mean that it's not still a threat, and there are some considerations that need to be taken into account. One of those considerations is really not so much about preventing the disease, but about preventing antimicrobial resistance. And drug-resistant TB is an enormous burden. Globally, it accounts for 1 in 3 AMR-related deaths. So in a 2015 report, what we saw is that multi-drug resistance killed a lot of people, 75 million people, and it could cost the global economy trillions. So this is not a small problem, and it's something that we need to really start focusing on. The US costs to treat multi-drug resistance are also pretty substantial. So we're talking about $500 million in 2020. And this is just an analysis that takes a look at costs that were done in 2014 and extrapolates them to 2020. So what you can see here is that, you know, there is a very significant, not just direct costs, but also societal costs in terms of productivity that we need to be concerned about. There's a number of other costs that we need to be thinking about when we're thinking about productivity, because it's not just productivity of an individual. Particularly when we're dealing with adults, we have to remember that they're all part of a family. And it's the ability to really take care of your family, whether it's watching your grandchildren or, you know, going to work yourself. This becomes very important. And from an equity standpoint, it's something that we cannot underline enough. So there are some lessons learned from previous rollouts in new vaccines. And there's a group at Hopkins that is leading an initiative called Smart for TB that has done some research and taken a look at what is it that will help determine success of any particular vaccines. And these are all things that we need to be thinking about now. not only do we need to make sure that the right vaccines are available, and, we need to think about the right targets, which populations they need to go into, what are the characteristics of the vaccines that become particularly important. Understanding the local disease burden, because it's not going to look like what it looks like overseas. We have non-US born people coming in, but they live very different lives and they live in different settings. So understanding that disease burden is particularly important. And then finally, under availability, resource planning is particularly important. It's not a given just because there's a lot of doses planned for vaccine that those vaccines will be available. And we've seen that over and over again, that ensuring that there is a pathway to affordable vaccine, available vaccine, for the entire world, this can be quite a challenge. We also need to be thinking about how do we set up systems for logistics planning. It's not just producing the vaccine, but making sure that the vaccines actually make it to the communities that they need to make it to. We need to make sure that vaccines are accessible. This means thinking about how are they delivered to different populations and different communities. It also means that we need to think about the existing infrastructure, and this type of planning is planning that should be happening right now, because it may not go through the usual places that vaccines are given. It may be in different type of settings, particularly when you consider which are the populations that would need the vaccines the most. And then if there's one thing that we've learned about COVID, from COVID, its acceptability, and thinking right now about, how are we going to address stigma? How are we going to address the anti-vaccine sentiment that we've experienced in the past? So doing some social science research right now is particularly important. Then from an equity standpoint, we want to make sure that we're also thinking about the populations. Now, these are global data that I'm talking about right now, but one of the things that we know is that no matter where you are in the world, TB has a disproportionate effect on families that are living in poverty. And what we're particularly concerned about are the families that are near the poverty line, because catastrophic expenses can push families even further into poverty. So these equity effects become particularly important. And the catastrophic expenses, as you can see here, are fairly significant. And then thinking about economic studies. Now, it's not just about the economics. Economic studies have been done globally, and they've shown that for every dollar invested, there is a return on investment of $7. This is in low and middle income countries that has a very different disease burden. So there is a need to do this in the US and look at it very specifically for target populations to understand what the economic case may be. What I would suspect is that, when you're talking about direct costs, it may be a very, very different type of scenario, but when you start focusing on some of the social and broader economic costs, you may see a very different case. And then there's some additional things that we need to be thinking about ahead of time. One of the big ones is politics. As we've seen from COVID vaccines, that when there is a global burden, these types of scenarios will need to be managed, and having an understanding of what global priorities are, where the US would fit in within those global priorities becomes very important, and just having a strategy to move forward. having a decision as to, are you moving in a parallel path? Are you, getting in line in terms of, taking a portion of the global supply, how that will actually work, and thinking about through those things ahead of time, particularly when there are multinational manufacturers. Working through those issues becomes particularly important. Thinking through the investments for strategy is particularly important. We mentioned delivery strategies and infrastructure. Stigma is a big thing, and particularly from an acceptability standpoint, thinking through that is important, as well as working ahead of time on vaccine pricing, which will have a significant impact. So in conclusion, there's been a lot of work on the global case. So the global case has been established. It is clear on a global basis. It is by no means clear on a country by country basis. So there's still a lot of work that needs to be done. And much of this will depend on the vaccines themselves and how well the vaccines meet the needs of the populations. But there's a number of things that, still need to be thought through. And those include definition of the target populations, the types of delivery strategies that are needed, doing your cost-effective analysis and figuring out what is the return on investment to be able to do that, particularly thinking about bringing in the broader value of vaccination. And this is the one thing that I would really encourage, is that it's not about cost-benefit studies or cost-effectiveness studies, but really establishing what is the broader value of vaccination given a number of different priorities. Really understanding the impact on multi-drug resistance, not only here in the US, but globally. Resource planning, supply and investment strategies, social science studies, and political advocacy will be particularly important. So that's all I had. I just wanted to acknowledge the group at Hopkins that helped put these together, and thank you for inviting me to speak to you today.
Thank you very much, Lois, and I want to thank all the members of this panel. We're running a bit over. We have time for one question or comment from members of the committee, if there are any. Well, we don't have any online, and I think you've all left us with a great deal to think about. We've come a long way, but we've got even further to go, it sounds like, for the TB candidate. Thank you all very much. So what we're going to do is we're going to move to our next panel, and we'll take a brief break after this next panel instead of before. Our next panel is Provider Payment, Addressing Barriers and Increasing Confidence. We're hosting this session on provider payment and ways to address barriers and increase confidence. In this session, we'll hear from Dr. Susan Genexo from the Centers for Medicare and Medicaid Services, Dr. Rachel Radzner from the Center for Medicare and Medicaid Services, Mary Beth Hance from the Centers for Medicare and Medicaid Services, Chris Riegel from America's Health Insurance Plans, and Mitchell Finkel, who's from Avalair. And our first presenter is Dr. Susan Genexo. I see you on the screen and your slides are up.
Fantastic, thank you. So I'll be covering
I think you're
Medicare.
muted.
Can you hear me now?
Can you raise the volume just a bit?
There we go. Can you hear me now?
Now you're loud and clear. Go ahead.
Fantastic, great. So along with Rachel, I'll be covering Medicare, and then Mary Beth will take over to discuss Medicaid. So just in case not all of you have made it a hobby to research Medicare payment policy in your free time, I'm going to go ahead and start with just a little bit of background here. So first, very basic, CMS runs Medicare, which is a federal health insurance program for those 65 and older, and for some people younger than 65 with disabilities and those with end-stage renal disease. Now, CMS also runs Medicaid, which will be covered separately as noted. So now the parts of Medicare. Medicare Part A is hospital insurance, and it helps cover what you can generally think of as inpatient care. Medicare Part B is medical insurance, and it helps cover things like doctor services, outpatient care, and some supplies, drugs, and preventative services. Part C, or Medicare Advantage plans, that's an alternative to original Medicare, which is Parts A and B, and it's run by private health insurers. And Part D generally covers prescription drugs, what we would generally call SAD drugs, which stands for self-administered, and refers to drugs that a patient can generally take on their own. Now, Medicare vaccine coverage falls under both Parts B and Part D. And how Medicare covers and pays for vaccines isn't just totally left up to CMS. It's largely defined by law, by the statute. So, for example, the statute tells us that Medicare Part B covers both the vaccine and the vaccine administration for pneumococcal, influenza, hepatitis B, and COVID-19 vaccines. And that the hepatitis B vaccine is only covered for those who are at high or intermediate risk of contracting hepatitis B. The statute also tells us that there is no coinsurance or deductible for these vaccines, and that the payment is based on 95% of the average wholesale price, the AWP, for the vaccine product, except when it's furnished in settings for which the payment is based on reasonable cost, such as a hospital outpatient department, a rural health clinic, or a federally qualified healthcare center. Some other preventative vaccines, such as the zoster vaccine for the prevention of shingles, are not specified for Medicare Part B coverage in the statute and are instead then covered by Medicare Part D. Part D also covers tetanus before a puncture, diphtheria, pertussis, whooping cough, and RSV vaccines. Notably, the statute prohibits CMS from interfering with the negotiations between drug manufacturers, pharmacies, and prescription drug plan sponsors, including their contracted PBMs, and generally prohibits CMS from instituting a pricing structure for Part D drugs. So that is a large difference between the pricing for Part B and Part D vaccines. Now, despite all of the challenges that exist within this space, access to vaccines, as well as their use, has increased for people with Medicare. For example, as a result of the Inflation Reduction Act, starting in 2023, patients with Medicare drug plans pay nothing out of pocket for adult vaccines recommended by the Advisory Committee on Immunization Practices. And over 10 million Medicare Part D enrollees received an ACIP recommended vaccine completely free of charge, which saved enrollees more than $400 million in out-of-pocket costs. And the majority of those enrollees who received vaccines did so for the prevention of RSV. Now, before I turn it over, I just want to note that CMS engages regularly with interested parties on how to improve program operations and payment systems and communicate any changes that we make. And we have a whole host of resources on our website to break down the intricacies of vaccination payment, like our easy billing guide for long-term care facilities and a whole lot of other things. And that's all in addition to the substantial annual rulemaking efforts that we perform every year, both on a fiscal and calendar year basis, which I'll turn it over to Rachel to cover. Thank you.
Rachel, we see you. You have the floor.
Thank you. Good afternoon. I'll be just discussing a few proposals related to vaccine payment from the 2025 Physician Fee Schedule proposed rule. First, we've proposed to allow people with Medicare to get hepatitis B vaccines from pharmacies and to allow pharmacies and mass immunizers to roster bill Medicare, consistent with billing that's currently done for flu, pneumococcal, and COVID-19 vaccines. This proposal is tied to another 2025 Physician Fee Schedule proposal, in which CMS proposed to expand coverage of hepatitis B vaccinations by revising the definition of those at intermediate risk to include individuals who have not previously received a completed hepatitis B vaccination series and individuals whose previous vaccination history is unknown. Currently, unlike pneumococcal influenza and COVID-19 vaccines, Medicare Part B only covers hepatitis B vaccines for those at intermediate or high risk of contracting hepatitis B, as Dr. Donesco mentioned. Therefore, Medicare Part B requires a physician to assess a patient's risk of contracting hepatitis B before administering the hepatitis B vaccine. Because the hepatitis B vaccine claim needs a physician's order, they can't be roster billed by mass immunizers at this time. And for a moment, we'll talk about some background on roster billing. CMS allows for roster billing when certain vaccines are administered in pharmacies. Roster billing gives vaccine administrators, meaning the people giving the vaccines, an easier way to submit one large claim for the patients who receive the same vaccine on the same day. Roster billing for vaccinations is available to those providers who Medicare refers to as mass immunizers. We define this term as a traditional provider, like a physician, or a non-traditional provider, like a drugstore, public health clinic, or senior center. We created the mass immunizer specialty for providers who wouldn't otherwise be eligible for Medicare enrollment. So, like we've been saying, Medicare currently allows for roster billing for certain vaccines given in pharmacies like flu, pneumococcal, and COVID-19. And as I mentioned earlier, we proposed changes that would allow roster billing for hepatitis B vaccines as well. So that's for one proposal. And now I'll discuss a second vaccine payment proposal from the 2025 physician fee schedule proposed rule. We proposed some changes for how we pay for vaccines in rural health clinics, RHCs, and federally qualified health centers, FQHCs. CMS proposed that payment for hepatitis B vaccines and their administration be made at 100% of reasonable cost in RHCs and FQHCs in order to continue to streamline payment for all Part B vaccines in those settings. So those are two proposals related to hepatitis B vaccines. And in addition, CMS proposed to allow RHCs and FQHCs to bill and be paid for Part B preventive vaccines and their administration at the time of service. We propose that payments for these claims will be made according to Part B preventive vaccine payment rates and other settings to be annually reconciled with the vaccine's actual vaccine costs on their cost reports. Due to the operational system changes needed to implement this proposal, we propose that these changes be effective on or after July 1st, 2025 for dates of service, beginning on or after July 1st, 2025. So the formal comment period for this proposed rule just ended. We are working on the final rule, and it's expected for release on or around November 1st, 2024. So that's it for Medicare, and I'll turn it over to our CMS colleague, Mary Beth Hands, to discuss provider payment for vaccines and Medicaid. Thank you.
Thank you very much, Rachel. Mary Beth, good to see you on the screen. Now, Mary Beth's also a member of the committee.
Great, thank you so much, and good to see you too. So thank you both to my CMS colleagues, and I am going to talk for a minute about Medicaid and CHIP, which is the other large program that CMS runs. In case you don't know, Medicaid provides health coverage to approximately 80 million Americans who are low-income adults, children, pregnant women, elderly adults, and people with disabilities. The Children's Health Insurance Program, or CHIP, provides healthcare coverage to children and families with incomes that are above Medicaid, but generally too low for private insurance. Medicaid and CHIP are both combined federal state programs. This means that states run their own programs, and they run Medicaid and CHIP separately. They're two separate programs within requirements established by the federal government and or CMS. As I said just a minute ago, Medicaid covers individuals of all ages. CHIP is primarily children through age 18. Most individuals in Medicaid and CHIP now have access to all vaccines, all ACIP recommended vaccines without cost sharing. This is thanks to the Inflation Reduction Act, which provided coverage for adults in traditional Medicaid. This was the last group within Medicaid that did not have mandatory coverage. Of course, there had always been optional coverage, but this was the last place where there had not been mandatory coverage. And this went into effect on October 1st of 2023. Also want to note, because I want to get it in here, that children enrolled in Medicaid receive vaccines primarily through the Vaccines for Children's program. CMS has recently issued guidance for states around coverage. We issued a state health official letter and fact sheet in June of 2023 ahead of the effective date to expand mandatory coverage of vaccines for adults. And we also released an updated vaccine toolkit in February of 2024. Our goal for the toolkit is it's basically a one-stop shop that provides a lot of information relating to Medicaid and CHIP vaccine coverage, payment issues, It's really kind of the introduction to vaccine coverage and vaccine issues in Medicaid and CHIP. Just to step back a minute and talk about how this all works. So states set their own payment rates for vaccines and vaccine administration fees. Of course, for children, the vaccines are free through the Vaccines for Children's program. Many states have undertaken significant efforts to increase or catch up on vaccines as we're coming out of the public health emergency. CMS strongly encourages states to consider using the many levers within the Medicaid program, the many levers that exist within the Medicaid program when implementing efforts to increase immunization rates. For example, we encourage states to look at their claims data and quality measurement data to assess whether there are specific areas within a state where immunization rates are lower. We also encourage states to partner with state health departments, immunization programs, other partners in the state to try and reach people and improve outreach and immunization rates. We also encourage the use of levers, such as within managed care. There's pay for performance, and state-directed payment levers. Within the fee-for-service space, there's also payment incentives. There are also levers that can be used to emphasize the importance of vaccines. We share CDC and other HHS components campaign materials with states, both so that they can use it and build from that in their activities, but also to really lean in on consistent messaging, so that there's consistent messaging coming from states and from HHS, CMS, CDC. We think that's extremely important. We also have the Connecting Kids to Coverage Insure Kids Now program, which is a communications program that encourages the importance of immunizations and also emphasizes that Medicaid and CHIP provide coverage of vaccines. This campaign includes print and radio communications, both in English and Spanish, but it also includes community members who amplify messaging, which helps get this information to communities, and it allows it to come from non-government entities. So we really have encouraged states to think about and undertake efforts to improve immunization rates. This includes thinking about payment rates. And as I've just highlighted, there are a number of levers within the Medicaid and CHIP programs that states have to lean in on in those efforts. Thank you.
Thank you, Mary Beth. Our next presenter is Chris Riegel from the America's Health Insurance Plans, and Chris is also a member of our committee. Chris.
Thank you very much, Dr. Hopkins. And thank you everyone for listening to this today. I've had the pleasure of serving on a panel with Dr. Janesco before, and she's incredibly insightful, and I'm thankful to share the stage with her again, proverbially, I guess, since I'm not on the same stage. You get the idea. Next slide, please. So I want to talk about the insurance landscape and what we are required to cover for vaccines in the United States under commercial insurance, and then I'll very briefly touch on Medicare and Medicaid insurance on the next slide, but those have already been covered. So on the slide that we're looking at here, this is clips from the Affordable Care Act sections that address vaccines and preventive services more broadly. The Affordable Care Act updated Section 2713 of the Public Health Services Act. And throughout our conversations with CDC and other public health partners, as well as other stakeholders, we found that there's a little bit of confusion and just nuance in the requirements that health plans are required to cover. So the provisions of the Affordable Care Act apply to, as is highlighted here, non-grandfathered group health plans and health insurance issuers. So that includes employer-based coverage, marketplace coverage, and until the Inflation Reduction Act, Medicaid expansion populations. So these plans must provide coverage for and must not impose any cost sharing on immunizations that are then defined below. Immunizations are those that are for routine use as recommended by ACIP, and they're defined as routine when they are listed on the immunization schedules by the CDC. And then the following section indicates that nothing in this section requires a health plan or issuer to provide coverage without cost sharing for out-of-network services, or even to provide those services out of network at all and provide coverage. So this effectively means that this must be done for in-network providers. And then the final point, that a planner or issuer must provide coverage for plan years that begin on or after the date, that is 1 year after the date of the recommendation. And this point has been really confusing in some of the conversations that we've had regarding respiratory vaccines and the like. What this means is that the recommendation, if a recommendation from ACIP were to occur today, it would not take effect or not be required for coverage without cost sharing by commercial insurance plans until January 1st, 2026. Now, I do want to specify that this is the floor for coverage. This is the baseline. Many health plans are going above and beyond this coverage. They are extending their networks. They are providing access to and coverage for vaccines that might not be considered routine. There might be other nuances that they're circumventing, and certainly some plans are providing coverage without cost sharing for vaccines prior to that required implementation date. So, next slide, please. This is just a very, very fast rundown of pretty much what the CMS team said regarding the Inflation Reduction Act. The IRA squeezed out a lot of the nuance and subtleties that were in the ACA. That there is no cost sharing beginning on or after January 1st, 2023, so a hard date. They said no cost sharing shall apply, no coinsurance, other cost sharing, and they will be treated as a covered Part D drug. So this is any vaccine rather than those that are considered routine. And when ACIP makes a recommendation, it takes effect immediately. Similarly, on the Medicaid side, these were vaccines that are approved and recommended, and their administration must be covered without cost sharing, effective October 1st, 2023, as was indicated in a previous presentation. So as you can tell, a lot of the stumbling points for commercial insurance, the ones that get challenged a lot, the ones that might cause some confusion, were addressed and mitigated in many ways in the IRA. Next slide, please. So as we have our ongoing conversations with CDC, public health officials, state officials, other stakeholders, we found some key issues bubbling up to the surface. And we're hearing from our health insurance plan partners that there are a number of challenges for the RSV immunizations specifically. As I'm sure everyone on this panel is aware, the RSV vaccines are recommended for seniors, newborns, pregnant women, and those at higher risk of severe RSV. But then the challenges arise. First issue, there are numerous products that are recommended and licensed for different populations. We have heard anecdotal stories where a pregnant woman receives a vaccine that has only been approved for seniors. And that's the result of some confusion in which product was recommended, which was approved, which was ordered, and then ultimately which was administered. Similarly, we've already seen a change in the recommendation for who among seniors should receive the vaccine and when. The previous recommendation from last summer called for shared clinical decision-making, which leaves some health plans to question whether this qualifies as routine and instead may be considered a risk-based vaccine. I do have to specify that there are compliance questions, federal compliance questions, so I can't say which plans do this or why they view things this way. We have merely heard from some of our plans that when a vaccine has shared clinical decision-making, it is no longer considered routine. Now, ACIP has updated that recommendation to make it a risk-based vaccine for ages 60 to 74, but recommended for all 75 plus. Now, again, that's commercial insurance. Medicare does not really get affected by that. There's questions about whether for the clinical effectiveness and recommendations for the maternal vaccine versus nirsevimab for a newborn. There are questions about whether nirsevimab should be administered in the hospital before a baby is discharged or in the clinic within the first week of life. And that does leave a difference. If somebody is discharged from the hospital, they have 1 week to get the vaccine, and not all clinics are stocking that vaccine, understandably, given the cost. Additionally, the nirsevimab has a seasonal recommendation from October through March. But in conversations with CDC, we're hearing that some public health officials would like to administer through, let's say, the month of April. Unfortunately, that's not in alignment with the recommendation. It throws off payment structures and the way this would be coded and reimbursed. And then finally, as I mentioned, that implementation timeline challenges that the RSV vaccine in particular for commercially insured people does not have to be covered without cost sharing until 1/1/25 because the original recommendation occurred in June of 2023. So as you can see, there are a lot of complicating factors here. And health plans, from our perspective, we want to work with everybody here, with all stakeholders, with all public health officials, with providers, to make sure people are getting the vaccines that they need without cost sharing. We want to expand access. We want to ensure that there's equitable access and that it's affordable. Of course, there are then the administrative challenges involving coding and making sure the right products are ordered and things like that. And that's where we really want to rely on this partnership to make sure that we are working together to address these challenges. When a vaccine order may show up at a health plan inappropriately with the wrong code on it, these are all reviewed by an algorithm. And yes, it may get pushed down the line with an appeal, but that's a complicating factor that adds additional layers of complexity. So we encourage providers, hospitals, and everybody to work with their health plan partners to help them with the coding, make sure that things are done quickly and easily so that we can make sure that the patient is not left holding the bag at the end of this. Next slide, please. Similarly, we have some different challenges with the pneumococcal vaccine. As I'm sure, again, all are aware who have MDs and research backgrounds above and beyond my credentials, CDC recommends that the pneumococcal vaccination be administered to children under 5 years and adults 65 and older who are at increased risk. The challenges here are that the recommendations are confusing and complex, especially with the timing and implementation. Since 2013, a 13, 15, 20, 21, and 23 valent vaccine have been approved and recommended, but they sometimes overlap with each other, and that requires a lot of challenges. We heard at the last ACIP meeting in June, for example, that a new product was recommended when the old recommendation had not yet taken effect. That just causes confusion. If you're a provider seeing that there's now a 23, a 21, and a 20, and only some of those are covered without cost sharing for the patient you're seeing, that adds a lot of complexity and confusion. And our concern is that things might get confused or might get coded incorrectly or maybe even administered incorrectly. And then we have to go back and make manual changes. So our hope is that we can all work together to close some of these gaps and make sure that people are getting the vaccines they need. We are fully supportive of vaccine access and making sure that people have equitable means to get those in an affordable way. And to do that, we all have to work together. We are all on the same team on this. I know I have to say that because some people view the insurance as a barrier. We don't want to be a barrier. We want to help facilitate in the right way. And I think that's my last slide. And, oh, excuse me. I have one more just outlining some solutions, things that we already talked about. We encourage ACIP to make recommendations as clear as possible and communicate them as clear as possible. We encourage coding to be, again, clearly communicated and as clear as possible so that they can easily be interpreted. Everyone must work together to implement these recommendations so that patients, again, are not the ones left getting a bill for this because there were some administrative challenges with coding or wrong site or something like that. And then finally, health plans on our side, we must continue to communicate with members about who should get what the recommendations say, how to access them. So again, just another layer of education to make sure that we can all work in the same direction. As it says at the bottom, we are partners in promoting vaccines in the most convenient and affordable ways possible. And we look forward to continuing our work with everybody, especially with these really exciting new vaccines like RSV and the new pneumococcal vaccines. And with that, I turn it back to you. Thank you.
Thank you very much, Chris. Our next presenter is Mitchell Finkel from Evelair. Mitchell, your slides are up. You have the floor.
Amazing. Thank you. Well, hello, everybody. My name is Mitchell Finkel. I'm a consultant at Evelair Health, a DC-based health consulting firm where I sit on our vaccine policy team and focus on vaccine policy. The goal of my presentation today is to give an overview of provider payment for vaccination. Before we could have an in-depth discussion about what payment rates look like, I wanted to level set the discussion today by going through the different steps that a provider goes through when they vaccinate a patient. You can see that there's many steps before the vaccination process, during the vaccination process, and after a vaccination process that a provider must go through in order to have a vaccine that is eventually paid for. The goal of payment policy is to ensure that all of these steps that a provider goes through, that payment at the very end accounts for all of these steps that they must encounter. You can see that before the vaccination process, a provider has to acquire a vaccine. They have to manage their inventory. During the vaccination process, they have to ensure that the beneficiary or the member they're seeing meets the ACIP criteria, and they often have to counsel the patient on the benefits of vaccination. And then finally, after the vaccination process, they have to submit that vaccination to an IIS system, as well as submit for reimbursement. And speaking of that reimbursement process, we heard Chris and CMS representatives talk through the coverage side of this. We saw the intricacies of coverage. Sometimes it's covered. There's other conditions. We also heard about the coding side of this, that you have to submit the correct diagnosis code, the correct product code, and the correct administration code. And all of that is going to eventually form the payment rate that a health plan or insurer will pay the provider for the vaccination. We know that the National Strategic Plan prioritizes adequacy of payment and ensuring that providers are compensated for their time that they spend vaccinating the patient. So we want to think about what is payment adequacy. And from a researcher's perspective, this is relatively difficult since the majority of payers, that payment rate is negotiated between the health plan and the provider. And every health plan and every provider could have a different rate that they're being paid in the majority of markets. You can see that is applied in Medicare Advantage, same with Medicare Part D, commercial, and Medicaid managed care. There are two markets, and our last presenters went over them, Medicare Part B fee-for-service and Medicaid fee-for-service, where rates are public and providers that is set by payment policy. So we heard CMS talk about how Medicare Part B fee-for-service pays a product at 95% of average wholesale price, which in other words is about 117.5% of the private sector cost or the list price. We can see that they establish a vaccine administration rate, $30 plus a geographic and a inflationary adjustment. So today that's about $32.57. And then we could also see that Medicaid fee-for-service, every single state in this country will set their own payment rate. And that's what I'm going to actually eventually discuss in terms of what Avalier did. So in the absence of knowing the payment rates in most markets, to really assess what is adequate and think about what is the National Strategic Plan telling us, we can rely on survey data on what providers are saying is their payment rates adequate. And you can see this chart on the right here where CDC researchers in 2018 asked providers, adult providers across different markets, whether they perceived a vaccine payment rate as adequate. And you can see it's separated by whether they lose money, break even on the product and administration, or make money. And you can see that for a majority of payers, so the commercial payers that have a fee-for-service arrangement, HMO arrangement, PPO arrangement, majority of providers report breaking even on that or making a slight profit. Similarly, you can see that in Medicare Part B and Medicare Part D. The clear exception to this graph here, however, is Medicaid. And we see overwhelmingly providers report losing money when vaccinating a Medicaid patient. And that has presented a lot of notable kind of areas for research. There's been a number of research reports, including one done by Avalier, which I'm going to go through on the next slide, as well as other studies have been done by Monat Health, as well as the Global Healthy Living Foundation. So speaking of that Medicaid rate, as I mentioned on that first slide, Medicaid fee-for-service rates, in other words, what the state is setting as a rate, are public, and it's published across all 50 states in the district in Puerto Rico. Additionally, so what we did is in 2024, we looked at each of those states' payment rates for both vaccine products and vaccine administrations with the support from Pfizer. You can see that we looked at adult payment rates. So if you have a patient over the age of 18, that's because the child, it would be under VFC. And we looked across 4 vaccine types, PCV20, COVID-19, maternal RSV, and shingles, as well as we looked at the administration fee. It is worth noting we only looked at Medicaid fee-for-service plans because this is the only one that's public. Medicaid managed care plans, those rates are private. However, it's generally assumed that they're similar. You can see in the chart on the right, we categorize whether a state was reimbursing below, at, or above a benchmarked rate. And this is important because you have to assess payment adequacy with something. And what we chose to assess it with is the Medicare Part B fee-for-service rate. So the one that we heard from the CMS presenters, and that's because most providers report that this is an adequate rate. As you can see, with the exception of COVID-19 vaccines, all the other vaccine products, the majority of states were being reimbursed below that benchmarked rate. You can see for PCV20, a little bit more states get it at that rate, but the majority are lower. And then you can see also for shingles, almost every state is reimbursing below that benchmark rate. We can also see for vaccine administration, every state was being reimbursed below that benchmark rate. So to give some context on what that benchmark rate is, for the Medicare Part B fee-for-service, or in other words, what we're defining as adequate, that's $32.57 that a provider would be reimbursed. And that is, it goes up from there based on, say, you're in Alaska, you would be reimbursed more, or New York City, while if you're in Kansas, it's a little less, but the national payment amount is $32.57. And in comparison, we looked at what is Medicaid reimbursing. The median Medicaid reimbursement rate we found was $14.70. So almost half what the Medicare Part B fee-for-service rate is. And other researchers have actually connected that payment rate, if you were to increase that payment rate, it would be associated with a higher vaccine coverage rate within Medicaid fee-for-service. So I think the important thing to think about here is we saw from the survey from providers that they overwhelmingly report that Medicaid reimburses low. When other researchers, including Avler, have looked at those rates, they also find that they are lower than other payer types, such as Medicare Part B fee-for-service. So a number of stakeholders have thought about what are those reforms we can be looking at. And this started in 2021, and I'm sure earlier, but with MACPAC, another federal advisory committee, thinking about what should those payment rates look at. And they said that you could establish a federal floor for payment rates in regulation or statutes. So that's one area one could look at. You could also think about in statute or in Congress via new legislation, increasing the federal match to state Medicaid programs to incentivize them to increase the reimbursement rate. You can also think about, what about a pharmacist versus a physician? Should they be reimbursed the same? And you could think about provider parity reforms. Finally, we know that Medicare and the coding environment really do influence the rates that Medicaid pays. So reforms to Medicare, such as covering all vaccines under Medicare Part B fee-for-service, would also have impacts on Medicaid. So I think those are just some of the policy solutions stakeholders have floated. There's a number of other ones in comment letters and white papers online, but I hope this was helpful and I appreciate the opportunity to speak today.
Thank you very much, Mitchell, and I want to thank all the members of the panel. Are there any questions or comments from the members of the committee in this room or online? Go ahead, Mitch. I see you.
Thank you all on the panel for the presentation and the insights. Couple of things that I just want to get a little more insights from our panel on. One is, and Mitchell, you mentioned it in your conversation that, Medicaid rates are all over the board and below. But one of the things that's a challenge for those who are trying to look at and analyze this is getting a central source for what is the rate that is being paid at the state level. And so for the folks who are from CMS, and specifically our colleague who's on the committee, Why can't Medicaid collect those and make it publicly available so people who are looking at it can look at, so that we can then have some policy discussions that would have a look at that. So that's one question there about getting access to what the rates are in Medicaid. So we could do some good comparison and try to make have the discussion about getting it to where a lot of providers in the system think it needs to be. So that's my first comment there. And I don't know if we want to take that one, or you want to ask all of them, or should I just wait?
Mary Beth, do you want to
Mary
go
Beth?
ahead and address that?
Sure, I'm happy to, let me get my video back on. Sure, I'm happy to address that. So as was previously mentioned, the fee-for-service information is available. Each state has a Medicaid state plan, and they also have physician fee schedules that are available publicly. And Medicare fee-for-service information is available there. Managed care information is pretty much proprietary information. And so that information is just not available. But there are thoughts that the rates are probably similar. So, you know, one could potentially work from the fee-for-service information that's publicly available. Does that help?
Not completely, but the reason I'm raising it, Mary Beth, is that if you ever try to go to each of the states to try to get the data, it's a big chore for anybody who's looking at it. So we have that available from CMS for Medicare. CMS is the payer, even though it's going through the states. CMS is the ultimate payer to the states for that. You know, why can't CMS collect that and make it available? Again, the whole purpose is to try to look at it, analyze it, make it easy for the discussions.
So, you know, as we highlighted, you know, Medicare and Medicaid are two very different programs. And, you know, Medicare sets the rates to the physician fee schedule, and I will stop to make sure I'm doing a very high level. I will be more than happy for my Medicare colleagues to correct me or add any other comments that they would like to add. You know, Medicaid is a state-federal partnership, which means that states set their rates, but they also, it is not all federal money. They're matching funds. And so, you know, a state pays a portion of the cost and the federal government pays a portion of the cost. So, you know, they're very different programs with very different purposes, and Medicaid really is intended to be a state-specific program. So, you know, we just don't have that information available collectively, you know, and, you know, we appreciate that you've asked for that. We can take that back and think about it, but that's not something that we do have available right now.
Okay, appreciate that. Question to our payers that are on this. One of the things that as we're coming into the respiratory season, and we heard earlier today about a public campaign for educating the public about the respiratory vaccines. But what we are seeing is that the system where patients are already coming in to get vaccinated, when providers are billing for those vaccines, it's not in the system yet. And so any thoughts in terms of, and this goes even broader than just CMS, it's also goes to CDC as well, is do we need to advocate for a buffer to allow the system to put in place until we could get some changes to the regulation that really gets the payer on track where our recommending bodies, ACIP, are coming. You know, as soon as FDA or CDC make a recommendation, patients are in providers' offices wanting to get vaccinated. And so the worst thing for those patients is them being turned away or provider having to lay the money out. Now with a lot of these vaccines having higher costs, that's a cash flow issue that then jeopardizes our community availability and access. So any thoughts on that?
Yeah, can I actually just ask one question? Because we know we heard about some of these last year, and we worked very closely with some of our partners at CDC and our health plans. Like, so it was the association, the plans themselves, and everybody, to making sure we could close these gaps. But think they were largely addressed. But if we're running into problems this season thus far, please send us examples and stories. The childhood vaccines are seasonal, so they haven't even started until October. But I'm sure there are people trying to get the vaccines, like you mentioned. I don't know how well stocked they are, things like that, but hopefully our systems are in place to be able to address this. But I'm more than happy to take it back to our partners to see what's going on.
Okay, yeah, we've got a couple of examples that we've got
Okay.
from providers that has been shared with CMS, but I'd
Okay.
be glad to that. And then the other thing that we're hearing from providers is the whole amount of time it takes to have that discussion with patients about, you know, for addressing vaccine confidence and the time it takes for that. I know there's work at the AMA committee about getting coding for that counseling time. Get some insights from a payer perspective. What's going to be needed to get that? You know, we can do the code, but to get it paid is going to be the big challenge.
Yeah, that certainly is a challenge because I don't think this was an issue that we necessarily predicted even 5, 6, 7 years ago. And it's only gotten increasingly more relevant. We are on some of the AMA CPT coding committees and help with the development of those. So I would have to defer to my coding colleagues who are unfortunately not on about what needs to be done. My guess, just my rudimentary understanding of coding is if there is a code, it is built into a negotiated rate. It is built into what the coverage for the vaccine without cost sharing. As you saw, that administration is covered. What about counseling? I think that's just something that needs to be worked through with an individual plan at this stage. But I don't see any reason that it wouldn't be covered. But I can't speak for all across the industry for that.
Thank you. Molly Howell.
Yes, thank you to the panel. Chris, I have a question for you, and then I have a quick question for Medicare. So one of the barriers to nirsevimab administration at the hospital is the bundled reimbursement or the bundle not being updated to include nirsevimab, which is about $500 a dose on the private market. What would it take for insurance to cover all vaccines at a hospital outside of the bundle? What would that look like, and what would that take?
Yeah, so we have had these conversations. That is definitely a challenge. And it seems to me that it's a lag. And that's the problem right now, is it's not built into the bundle. It's not built into a negotiated rate. And, you know, when you're talking about different well, that's a bad terminology, VFC being a provider of so many vaccines in hospitals, that's an entirely different issue. But we do understand that, like you said, that's a $518 vaccine that somebody has to pay for at this point. It's the biggest challenge is that it's not built into that negotiated payment right now. And one of my colleagues had indicated in other conversations with the AHA and others that this is just going to have to take a little time to roll into the payments. And it seems like we're in a weird kind of gap right now, and we hope that nobody's not covered. We've heard from CDC that babies are now being encouraged to get it in the hospital as opposed to in the clinic, given the handoff challenges. But I think this is an issue that we are actively addressing, and it's going to be that next negotiation when it gets built into it. All the actuarial models and all the, you know, the business cases have already been built out for the next kind of season, for this, you know, 2024, 2025 season. And that's definitely a challenge. So I'm hoping that that gets addressed in the next seasonal respiratory season, but no doubt about it that there are some loopholes, some gaps that are leaving people uncovered. And I know I repeated the phrase multiple times. This is the example of the patient being left kind of looking at their hands and saying, how is this my fault? I think that what it comes down to is this is going to have to be something that's addressed. Hospitals and health plans just working together to find whatever solution it is for this year, and then making a permanent solution thereafter. I hope that's helpful.
It is. Unfortunately, I think a lot of hospitals just aren't able then to take it on. And so that's leaving kids maybe not getting nirsevimab at the best time.
Yeah.
So Medicare, I was just wondering, you didn't, at least I didn't catch you addressing Advantage plans and what impact Medicare Advantage plans may have on vaccine reimbursement. My understanding is some people may be out of network and then immunizations wouldn't be covered. Is that correct through an Advantage plan? Or are vaccines not under the Advantage plan at all?
So, I mean, the vaccines are covered under Part D. They're covered under B and D. So Medicare Advantage plans can obviously have both B and D. Not all of them, but some have the D coverage as well. So I guess, are you saying that your experience or that they're not covering some of the vaccines?
I think what I think what's happening is, for instance, if a patient goes to local public health to get a vaccine and local public health isn't a part of their Medicaid Advantage or their network through the Medicare Advantage plan, then that dose isn't getting reimbursed because they're considered out of network, is my understanding.
I may actually have to call on, unless you know, I may actually have to call on Chris here for some help. I'm on the B side, so that's actually not a situation I'm familiar with.
Yeah, I mean, on the B side, Medicare Advantage needs to cover all Part A and Part B benefits. So I don't know exactly what happens when they go to an out-of-network provider, but all of the B vaccines, like we mentioned, pneumococcal, flu, COVID, and for some hepatitis B, should be covered by the Medicare Advantage plan. And that's what we can speak to. Like Susan said, we don't have a Medicare Advantage colleague on, but if we're talking about Part D, then we get into the Part D plan specifics.
Yeah, and unfortunately, I know this is not the best move for me, but I actually don't know that how this works. But you're absolutely right that Medicare Advantage plans can build out networks. I don't know how that applies to a public health site, like you indicated. I believe there's a presentation this morning that said the public health sites actually have a lot of difficulties billing, and that is one of the reasons why there might be a gap. But I have not heard of instances of people whose claims to a public health site get rejected, but I certainly can take that back to anyone internally if that's an issue that's coming up. Like has been mentioned, the IRA closed a lot of the loopholes, so I don't know that that's an issue I've heard of yet.
I want to thank all of the members of this panel. It's been very enlightening. Obviously, there are a number of challenges for us to continue to work through to get our patients vaccinated and have them come through with financially whole. And thank you all for your time and your presentations. We're now going to take a break. We will come back at 4:35 and start our last discussion for the day. We'll be talking about the National Strategy Charge working session. Thank you for joining us for our first day of our September NBAC meeting.
Produced by the U.S. Department of Health and Human Services.